Thanks, everyone. I'm Ed McFarland. I'm from Baltimore, Maryland, and it's a real honor to be here. I'd like to thank the Manos brothers. They don't look like brothers, but I think they got me here. I also like to recognize Stathis Chronopoulos, who's a good friend of mine. He was a fellow with us back in the good old days. I also like to thank the moderators for introducing me. So I'm going to ask everyone to stretch their minds a little bit today. Earlier there was a little controversy about what to do for rotator cuff tears and what is the pathophysiology. And part of this talk is also for my friend from Louisiana. So we have differing opinions, as is reasonable where there's uncertainty. But anyway, we're going to talk about whether you should do any acromioplasty at all, and also whether an anterior or lateral acromioplasty is necessary when you're doing rotator cuff repairs, or when you start talking about rotator cuff disease. So these are my, actually I guess I got right in my, I don't have any conflicts. But anyway, so history of acromioplasty is quite interesting, actually. I think it's important to know the history of the disease, or what we think is a disease. We're also going to talk a little bit about a critical evaluation of not only regular anterior acromioplasty, but lateral acromioplasty in the literature, and also hopefully come to some tentative conclusions. So it's interesting that if you really go back to the history of impingement, it really wasn't called impingement for a couple centuries. The first mention of it was back in 1867, when there was no imaging or other things. And most of the surgeons in the early 20th century thought that trauma was actually the cause of most rotator cuff tears, because that's how they usually presented. Codman, though, who, as we all know, is sort of considered the father of shoulder surgery, wrote his famous book in 1933. And he felt that rotator cuff tears were largely a degenerative lesion. So already in the early 20th century, we've got a disagreement on whether it's a disease of attrition or whether it's because people had tears from trauma. And in fact, it probably in many people is both. So the problem we have from the very beginning is that someone noticed that one of the things that people have when they have cuff tears is they have acromial spurs, or a shape of the chromium that's maybe abnormal or malformed, and they have a rotator cuff tear. So we have these two observations, and like anything else in medicine, do those two observations, how do they relate to each other? So the conclusion had been early on that because of acromial shape, that went on and caused rotator cuff tears. But the reality of it is, it could have just as easily been the other way around. So we've all thought about rotator abnormal acromions or spurs being associated with rotator cuff tears, but maybe the tear caused the spurs. Or maybe they're not related at all. Maybe they're both degenerative lesions, and they just happen to occur at the same time. So again, it takes a little jump of faith to understand or try to decide which side is which. So basically then, and it's been underlined in the previous talks, we have two basic problems. Is it an intrinsic disease of the tendon, or is it due to the impingement of the tendon on something else? Is that, and it's been in the past, been the acromion, the CA ligament, the coracoid, the superior glenoid and internal impingement, or maybe even AC spurs. So some people, as you know, take the spurs off the AC joint, some don't. Does the rotator cuff actually impinge at the level of the AC joint? It's a good question. So Neer's contribution prior to Neer, so the concept of impingement started about in the 1960s or 70s. So we call it this, and he described three stages, of course. The first was edema, hemorrhage, fibrous and tendonitis, bone spurs and tendon spurs. This article, when I was a resident, was religion. And he, as a result, suggested that partial acromioplasty, his big contribution really to rotator cuff disease, was instead of doing a total acromiectomy, which was the solution for rotator cuff disease up until the 60s, 50s, or 60s, he was the first to say that you should probably do it a partial acromioplasty, because you can imagine a total acromiectomy leaves people with some significant weakness, but it did, oddly enough, take care of their pain. So then Morrison came around in the mid-80s, and he, with Dr. Bigliani, described in an abstract 3 different shapes of the acromion. And so they noticed that the hook type was associated with increasing age, but they also noticed that it was associated with rotator cuff tears. They didn't exactly say how those were causally related, but that became dogma. The fact is, though, that subsequent studies, many of them, in fact, most of them, in fact, show that studies that different examiners have a very difficult agreement on what shape the acromion is. So if you take everybody in this room and you show them 100 pictures, the agreement is going to be less than 50%. The other thing too is if it really depends on the angle of the radiograph. So early on, when I was first starting, we could never get one tech to shoot the film right so that we could tell what shape the acromion was. And if they shot it a different direction, it was a different shape of the acromion. So again, reproducibility of these X-rays has sort of bothered us since then. I, in fact, do not get scapular Ys any longer because I don't think they add anything. So then the next thing that came along was studies that showed that changing the acromial shape did not really affect the progression of rotator cuff disease. So we've all been taught to do partial acromioplasties, but there's really good evidence that doing one doesn't really change how rotator cuff disease progresses in any one person. Also, there's never been any study that's shown that converting a type 1 acromion, any type of acromion to type 1 prevents re-tearing of the rotator cuff even after it's been repaired. So already there starts to be some chinks in the concept of impingement as it relates to the anterolateral acromion. So then Dr. Moorman, this is really a sleeper paper, in 1996 did a biomechanical study where he found that the CA ligament prevents superior subluxation. Part of the near acromioplasty in the past was to take the entire front of the acromion off, totally release the CA ligament, and then reattach the deltoid. The problem with that is noticed here is once you do that, particularly if someone has a massive rotator cuff tear, then they get superior subluxation and the greater tuberosity starts to hit the acromion. So he was the first to notice that the CA ligament, God put it there for a reason, and that is to prevent superior subluxation of the shoulder. It wasn't put there apparently to cause impingement. So then Madison put another nail in the coffin when he's in 2001 actually, this is a long time ago now, looked prospectively at 96 papers and didn't do an acromioplasty at all, and the results of his rotator cuff repairs were the same as a control retrospective or a case control group. And so already in the early 2000s we've got evidence that doing a acromioplasty doesn't make any difference. Another study by McDonald, it was this time a randomized controlled study, found that there was no change in the surgical results with or without acromioplasty. So it seems a little odd, but most of us think that that's religion. Jones and Lancet did even a better study where they did a prospective randomized study, and they found that acromioplasty versus bursectomy, there was no difference in the clinical result. And that's probably because most of the primary alpha nerve findings for pain or fibers for pain are actually in the bursa. The number 2 tissue with free nerve end findings is in the biceps, which all sort of goes along with what we see clinically. And if you still don't believe it, these are all systematic reviews of the articles done in the past 20 years on the effect of acromioplasty, either need for acromioplasty and rotator cuff disease. And they all conclude the same thing. Acromioplasty is not necessary for a good result in the treatment of rotator cuff disease. So it gets worse, actually, or one thing that's important to know is that if you do take this CA ligament and do an anterior acromioplasty, it can actually make people worse in some instances. So if you have somebody with a massive rotator cuff tear or large cuff tear, and you take the CA ligament and the anterior acromion, then the patient's it's going to worsen their superior subluxation. And then they, of course, get pseudoparalysis, or they get stuck, or they get arthritis. So actually, you probably shouldn't take the CA ligament, particularly in people who have large tears. The other thing, and this is basically what happens, is if you take it out, then you get this superior subluxation pattern like this. And that happened to me in the mid-90s, and I was very mystified, because I was doing everything that Neer said was right, and my patient came out like this. So now we know 20 years later why that's the case. So when do I do an anterior acromioplasty? First off, almost never. I haven't done an acromioplasty since 2005, and I have to tell you honestly, level 5 evidence, I can't say that it makes any difference in how the patients get pain relief or how they recover. I do, however, do it in patients who have rotator cuff syndrome where there's really nothing else. I think taking out the bursa in that situation is probably the best, and sometimes I'll do a limited anterior or lateral acromioplasty, but I don't think it really changes their result. Patients who have partial tears with no full thickness tears, sometimes I'll do it in them as well, but otherwise I don't think acromioplasty is necessary for any of these patients. So again, I avoid acromioplasty, and particularly CA ligament release in patients with massive tears. So that brings us now to the critical shoulder angle. The concept is, as mentioned earlier, been popularized by Dr. Gerber and his group, and it's basically the angle between the glenoid and the lateral edge of the acromion. And so he's done some biomechanical studies and some biologic studies suggesting suggesting it's a predictor of rotator cuff disease in that it increases the deltoid load. So basically, the idea is that lateral overhang contributes to impingement, so removing it should prevent rotator cuff disease and prevent failure of the repairs. So his recent study just published on his clinical results, he had 49 patients. He had rotator cuff repairs with the lateral acromioplasty. He had 14% failures, and he found that those that had a larger angle had more failed repairs. He concluded that doing this caused no harm to the deltoid origin, which I think is important. You shouldn't really take off more bone than necessary because you can detach the deltoid. But he did say that insufficient correction of the angle increased the re-tear rate and also decreased strength. This is a systematic review that just came out last year, though, looking at the published studies on critical angle. And they concluded that the heterogeneity of the studies, meaning that they really just weren't good studies, basically, and they concluded it remains unclear if the lateral angle affects clinical outcomes at all. So again, we still have the same issue that we had with the previous observations. You have increased overhang. Does that cause rotator cuff disease? Or maybe it's the other way around. Or are they maybe not related to each other at all? So again, we start planning our treatment over concepts that are not particularly satisfying. So in conclusion, the role of the chromic in rotator cuff disease is not established, as was mentioned in some of the previous discussions. There's no evidence that a partial acromioplasty, either anterior or lateral, prevents rotator cuff disease progression. And there's also no evidence, that, particularly for partial anterior acromioplasty, that's necessary for the treatment of rotator cuff disease at all. So the role of critical angle also has not been established in rotator cuff disease. There's currently no evidence that lateral acromioplasty is necessary for the successful treatment of rotator cuff disease. I think it does help you see when you're doing an arthroscopic repair, but it's not absolutely necessary. Above all, though, I think if you're going to do these types of procedures on patients, you have to be very careful who you do them on. These are both patients of mine that had no acromioplasty at all, and they're very happy. So I can say anecdotally, from my point of view, that it's not necessary to mess with the chromium when you're doing rotator cuff surgery. But I think you have to be careful that you choose the right patient and do what you think's right in your situation. Thanks very much.